So I think this is a theme to the good, the bad, and the ugly. Our three guests coming up will be hosting our case reviews, our case roundup. Just really quickly, this will be also done tomorrow. So that was Katie. And on Saturday, but the cases will all be different than today, so it will not be a repeat. So if you come for the next two, which I highly suggest, please do so. So is Mac joining us? Or no? Is it two of you or Mac?
He's there.
Where's Mac? Oh, there he is. There he is. Okay, so we got three highly entertaining individuals. The first is the dynamic Dr. Katie Russell from the University of Utah. The next is the highly entertaining Dr. Brian Coakley from Mount Sinai Medical Center. And finally, last but not least, who's still making his way up, is The Rock, Dr. Matt Harmon from the University of Buffalo. So take it away, please.
All right, I'm glad people are sticking around. Let's get some people in from the hall. So we're going to liven it up, guys. So this session, I think everybody remembers it. This is the same case controversy session that Mac and Todd Ponsky have run for years, and we're just mixing it up a little bit this year. So we're going to be 3 sessions, and they're going to be shorter chunks, and there's a lot of audience participation. So with that, Brian's going to lead us today.
Yep. And the last thing I want to add to what Katie said is this is meant to be very interactive if you haven't been in the session. We want to hear from you. We want to hear what you do in your practice. With that said, participation in terms of verbal comments is voluntary, unless we call on you, and then it's mandatory. All right, so first case is going to be talk about something.
Brian,
Yeah, go ahead.
before we get going, can we make sure the polls are working?
Yeah.
Are we on the app or are we on the poll everywhere? So we're on poll everywhere.
That's right. Do we have?
We need everybody voting, so everybody get ready for that.
Katie. How do we go back? You can only go forward. There we go.
All right, let's give them a minute, just a
Yeah.
couple minutes to get up on poll everywhere.
Nice. You good to go? All right. So let's start with something we heard one of our great Tech Talk speakers talk about just a few hours ago, perianal abscess. First case is a 6-month-old boy with a perianal abscess. Looks just like this. Parent says it's been treated by the pediatrician for 7 days with Augmentin and now shows up in your ER looking like this. So, APSO, what are you going to do? Antibiotics alone, aspirate it, incision and drainage, or go to the OR, incision, EUA, drainage, and even a fistulotomy.
Shannon, what do you think they're going to say? Two-thirds IND.
2/3 IND, okay. Let's see what we got here. Almost nailed it. We got about, looks like 62%, 63% say IND, 16% aspirate, 8% just antibiotics, and about 14% for the big guns. Anybody want to talk about, anybody who said aspirate? I would love to hear from someone who gave option B. 15% of you said it.
Well, to be honest with you, I usually use a needle tip and just make that nick with the needle. So whether that counts as aspiration or IND, I'm not sure.
During our tech talk, I didn't see any figures about mortality or major morbidity. I think for a lot of these kids, nothing happens. So why do anything at all?
Yep.
Tara Lou, Geisinger Medical Center. So I actually, based on the tech talk, changed my answer from IND to aspirate on the initial session, mostly because it sounded like non-operative management had a pretty decent success rate, almost equivalent to IND. So that's why I chose aspirate.
All right, great.
So I'm
Yep.
another aspirator, Rob Weinsheimer from Swedish in Seattle. It's a flick. It's the flick technique. So 18 gauge needle, put some EMLA to soothe parents' concerns, and then 18 gauge needle, basically on the way out, it works like a scalpel. So
Brian, you need to go to the next question.
Yeah, I know. I was just going to say, you just led us perfectly into the next question. If we can, how do we move forward, though? Thank you. So, what's your weapon of choice?
How many flick techniques?
You're right. The knife, the needle, or the machete?
Yeah, the needle functions as a scalpel, but the parent doesn't think that's what's happening. So
Yeah. Okay, let's go to the next question. So, after you drain it, what do you do with antibiotics? No more 1 to 3 days, 5 to 10 days, or until you see them back in clinic and make sure it's all better? Okay, so it looks like we got about 60% saying they would not give any more antibiotics. As my institution's NISQIP antibiotic stewardship champion, I just want to say yes. But we have about 12% saying 1 to 3 days, and another, about a quarter saying 5 to 10 days.
Hey, Shannon, will you clarify this too, like just the hygiene group? So that's no IND and no antibiotics, just do sitz baths.
We pulled all those literature together. So the non-operative management data that I presented, it was a combination of every series that used some version of non-operative management. So there weren't any that were non-operative, just hygiene and sitz baths alone. There was one series that was hygiene, sitz baths, topical antibiotics, 4 with hygiene, sitz baths, and oral or IV antibiotics. And then others who we pulled the needle aspiration and the non-op management data that I presented, and then also some series where they encouraged the parents to apply gentle pressure to see if they get it to drain spontaneously. There's not enough data on any of those.
I think we got a comment in the back.
Shannon, can you tell us, because you grouped together the needle aspiration with the non-operative, can you separate those two? Because many of us in the audience don't see those two as the same thing.
Yeah, that's a fair question, Romeo. So there were 2 series, or it was either 1 or 2 manuscripts. So one single center retrospective review that they either, if the abscess wasn't draining spontaneously, then they did a needle aspiration. So that's why we pulled it together. There was no one who just said, our approach was needle aspiration, and these are the outcomes of the patients who underwent needle aspiration. So the trouble is the question that we're trying to answer, like there aren't any literature on it.
Dr. Gulak.
Hey, Brian here. So I love that you guys hate antibiotics, me too, but in this case I use it, and I use it because there is data in the adult literature that the antibiotics, if it's a perianal abscess, do reduce the rate of a fistula formation. And that's my reason for antibiotic use.
Okay.
are you an adult surgeon?
All right, we're going to move to the next question. So the baby is now 9 months old and pops up with a recurrence. What do you do now? Restart antibiotics, aspirate it, IND, go to the OR to EUA, drainage and fistulotomy, or something that we couldn't think of? And the answer is, looks like about half would go to the OR for EUA, drainage, and fistulotomy. Do we have anyone who could say what, answer E, who want to do something else, what that would be? Nobody brave? Okay. Yep, well, there's someone here.
Hey, Brian.
Hi.
Sonia Butterworth here from BC Children's. For myself personally, I would just do what I did in the first case, which is just hygiene and observe and lots of sitz baths unless the kid was systemically unwell. So that was other for me.
Right.
So I had one other thing. I would go to the OR and do a fistulotomy. However, one of my older colleagues mentioned something about recurrence in the setting of iron deficiency anemia. So I have actually sent iron studies before on recurrences and found one patient that had a low iron, and I started iron supplementation. And by the time we got to the point where we went back to the OR, it was cleared up. Take that for what it's worth. It might be old lore.
So about half will go to the OR for a fistulotomy after the first.
Right.
After the first.
At the first recurrence.
Yeah. What about the Oregon group? I know the Oregon group, never goes. Right? Anyone here? All right, let's go next question.
Let's go to the next one.
I think Pat, keep going.
Oh, sorry.
Oh, there she is.
Hey, sorry, Elizabeth Wokalski from OHSU. So we're actually studying this. I think a lot of people in this room are actually involved in this study, but at OHSU we have a protocol that focuses on non-operative management. When I reviewed the literature when we started this a few years ago, the data is really mixed. I mean, and looking at our patients at OHSU, as you guys know, it's all really subjective. And what is really a recurrence? What is a fistula? You know, we're not examining these patients under anesthesia to know if they really have a fistula or if it's a recurrence or what. And so we actually have a protocol that focuses on non-operative management, and we're looking at time to resolution from the onset of this until the issue is completely resolved. And so we focus on just hygiene, antibiotics initially. We do discuss needle aspiration just for symptom management. So if they have big fluctuant, 2 centimeter fluctuant abscess that's really painful, you can needle aspirate it, which is probably the same thing as the flick with the needle, but we try to avoid IND because there's some thought that it increases fistula formation and prolongs the process. So yeah, so for us would be exactly what was mentioned, is just hygiene and sitz baths.
Okay. Should we go? Yeah. Should we go to the next case, Katie?
Yeah.
Yeah. Let's go to case 2. So we're going to switch gears. This 2-year-old female shows up in the ER, cough, fever, lethargic, generally looks unwell. This is a chest x-ray, big right, sided, effusion, and some consolidation. So what do? Antibiotics only, antibiotics and place a chest tube, antibiotics chest tube and put in some fibrinolytics, or antibiotics and go to the OR. Hmm. 2 days. Symptoms for 2 days. Needing a couple liters of oxygen, yeah, to maintain satisfactory saturations. Breathing's a little labored. All right. So it looks like we have about 10% saying antibiotics only, and about pretty equal distribution saying just add a chest tube or just add a chest tube and put in some fibrinolytics. Interesting.
I think I would like to see whether the fluid completely resolves if you put the tube in and then decide whether you need fibrinolytics or not.
Okay. Let's go to the next question. Okay, so for everybody who wanted to put in a chest tube, which was the vast majority, who places the chest tube where you work? Is it you, the PICU, the ER, or IR, or depends on the watch? Okay, thank you. So it looks like about a quarter falls on us, much less so the PICU. IR maybe doing about a third, and it depends as being the plurality of the responses. I can certainly identify with that. Yep.
This is David Klima, St. Luke's, Boise. And it really depends on kind of if it's a loculated effusion, if it's something a little bit smaller that really has a focal abscess, or if we feel like ultrasound guidance would be helpful, then we have interventional radiology do it. Otherwise, usually it's us or the PICU.
Okay. Let's go to the next question. Okay, so for those who added in the fibrinolytics, which was I think about 45%, how long do you keep those fibrinolytics going? 1 day, 3 days, 5 days, 7 days, based on the output, or until your partner takes over the service?
Not much controversy there.
Yep. What's that?
Not much controversy there. Look at that.
No, it looks like we have pretty much consensus on this one.
Where does that come? Is that the Kansas City data? Like, we're all pretty
Yep.
consistent on that. Yeah.
Yep.
Rebecca, you want to talk on the data? You know, I mean, I know it was
That'd be
before your
great.
time, yeah? But
was before my time, but proud to represent. So, similar to what the audience has said, interventional radiology often, because it's kind of like a pediatrics admission with a pneumonia, et cetera, IR often places a chest tube. If it's a large effusion, then surgery places it, and then it's 3 days, essentially 3 doses each day of TPA administered through the chest tube.
I wanted to ask that same exact question, which is, we all say 3 days because of the Kansas City data, but anybody from Kansas City or was involved in that early studies, why'd you choose 3 days? Was there any actual research into that? Or was that just, sounds like a good number, let's use it, and now we're all stuck with 3?
Dr. Holcomb said. She says there's always data.
I'm from Kansas City. I don't know why we chose 3 days. I assume Sean did based on previous studies, but there was another randomized study at approximately the same time that used the same protocol and had the exact same failure rate. So I don't think we've done a VATS procedure, and I haven't done one in between 5 and 10 years, and I don't think anybody's done one at our hospital in the last 5 years.
Yep.
Not from Kansas City, but I just gave a kid 6 days of TPA because he continued to have good output. So I don't just do 3 days if things are, continuing to progress.
Yep.
Hi, like most people here, we have both IR or surgery taking care of putting the chest tube in. We did evolve our practice though to having surgery involved, even if IR is doing the tube placement, because they can't take care of our pediatric chest tubes at all. So if there's a problem, I'd rather know what they're doing, because sometimes they put that tube in and stuff happens, and then you're caught in the middle of a problem. The other thing is with the TPA, we do the 3 days, but if on the second day it looks like there's nothing coming out, I do get a chest x-ray or an ultrasound to see if there's resolution of fluid. Because if there's resolution of fluid, then you don't necessarily need to give extra TPA, which has complications as well. So although we follow the guidelines, as you know, guidelines need to be individualized to the patient.
Yep, you got a comment over here?
So honestly, I probably would get further imaging before I gave that kid TPA. Because I've just seen in my practice, at least in the past few years, these horrible necrotizing pneumonias where the parenchyma is like melting into the pleural space. And, I don't know if TPA might make it more likely for you to get a bronchopleural fistula in that scenario, but I do worry about it. And I do worry about it causing bleeding. And I don't know, an x-ray like that would worry me. I'd hesitate before I just went ahead with TPA.
Okay.
That was a pretty good segue.
I was going to
Brian.
say, can we go to the next
Do you want to tell us what happens?
portion? Not really, but I guess we have to. Can we go to the next slide? So the patient did get TPA. And she, however, continued to remain ill and now has still persistently elevated inflammatory markers. CT scans done shows a large underlying pneumonia with a large loculated hydropneumothorax. So what do you do now? Add another chest tube, decorticate her while she's in the PICU, take her to the OR, and decorticate her open, or VATS, or do something entirely different. Not yet. So it looks like it's about 50-50. It would add another chest tube, and some would go to the OR to decorticate the pleural space. All right, let's go forward. So this patient got an open decortication while in the PICU. The right lung expands, but she did develop a bronchopleural fistula. Chest CT was repeated, shows right upper lobe atelectasis with lots of internal necrosis and hematocele development. PICU asks you to please just make it all go away and just resect the right upper lobe. Those were actual words. What do you do now? Do you do a left main stem intubation to try to get the fistula to close? Say you'll go debride the right upper lobe. No, you'll go resect the whole right upper lobe, or you just take out the right lung or something else. All right, we got a lot of something else, so we should be able to hear from, yep.
I mean, I honestly would leave it alone. Those can take a long time to heal, and I feel like you can do more harm than good by intervening.
Okay.
Yeah, I agree with that. Leave it alone, but I would go one step further, and I wouldn't have done the open decortication to start with. I would have put the tube in and left it alone, because they would tend to heal. Even if you get a air leak, you just leave the tube in. Once the pneumonia heals, the lung heals.
Okay. I think see a comment over here, Katie.
No trika.
Hey, Kate. I think leaving it alone initially is reasonable, but if it keeps going, then I think at that point I consider a blood patch.
Okay. Yep.
I think one of the things you got to do is have a stall technique for the people that are looking at the tube and the patient and the x-rays. And so this is when I start to undo the premature diagnostic closure, and I ask them if they got cocci titers, and I ask them if they did a TB test, and I ask them, right, make sure that we're not going to go and do something crazy. I'm from Central California, which is the original site of cocci, not the Arizona Valley.
Okay. Maybe we can go forward, just give the epilogue, and then we'll do the last case. So we went with the something else option 2. This patient ended up getting cannulated onto ECMO, as you can see, and we had an interventional pulmonologist place endobronchial valves, which closed off the flow, and she, of course, had a very long course, eventually did get a tracheostomy, but recovered, kept her lung, and now has been decannulated and is essentially back in her preschool and doing quite well. But it was a challenging case, to say the least. And you can probably imagine there was not uniform agreement between us and the PICU about what the treatment should be. All right, let's go to case 3. So this is a 15-year-old male, presents to the ER with right-sided chest pain and some dyspnea. Chest x-ray, as you can see here, shows a moderately sized pneumothorax on the right side. What is your initial treatment? Observe just with some oxygen, just aspirate the right chest, or you place a chest tube, or go to the OR and do a VATS. First episode, yes. Okay, so it looks like we have about 20% saying just admit and observe with oxygen via non-rebreather. About a quarter said aspirate the right chest, and half place a chest tube and admit, and just 1% going straight to the OR. Can anyone who does, I'm curious, anyone talk about aspiration of the chest, if they do that at their institution, how they specifically do that? I'd love to hear about that. Yep.
So Mark Mikulski, Nationwide Children's Hospital in Columbus. We've been doing that probably for the better part of 6 or 7 years now. We created a uniform clinical pathway. Out of necessity, we found on some review that we had just a wild disparity in terms of how people were treating within our group. And so this pathway came up. We aspirate with a pigtail. We evacuate all of the air and then put the Plurivac to water seal. I think, and if any of my colleagues are here, maybe my fellows, I can't remember exactly how many hours we wait for a chest x-ray, but if the chest x-ray shows full expansion, we pull the tube, observe them for a little bit, and then send them home afterwards. For someone that doesn't get complete re-expansion, we then we leave the pigtail obviously in place, and we put them on suction for 48 hours, and then kind of go through the pathway that way. We've had fairly good success with that model, so that's pretty much the way we do it in Columbus.
Okay. Yep.
So I'm at Michigan, Aaron Perone, and I was not on the study team who developed it, but if anybody from the Midwest Pediatric Surgical Consortium can speak more. But we put in a chest tube, I believe, we aspirate, and then actually just leave it clamped to get a repeat x-ray in about 4 hours. If the pneumothorax hasn't come back, pull the chest tube out, or the pigtail, and send the kid home. What's currently we have moved to just watching the patient, not aspirating, and if things don't get worse, sending the patient home, which made me very nervous. It just didn't register in my mind to do that, but I have an N of 1 where the patient did fine. In my follow-up clinic, he had re-expanded on his own.
Wow, okay. Let's go to the next question. So for those placing a chest tube, which was most of us, what kind of chest tube do you place? A pigtail catheter via Seldinger technique, a straight chest tube via Seldinger technique, or a chest tube with the traditional open technique? So I think this one speaks for itself. Okay, let's go next. So if you didn't do upfront VATS, which was almost nobody, what triggers the need for a VATS? Is it the presence of an air leak initially when the chest tube goes in, a persistence of an air leak for some period of time, or do you just wait for the second episode, or you go after it with imaging and look for blebs? Okay, so it looks like the vast majority say persistence of air leak for some period of time.
Anybody want to comment on it depends?
Well, we changed it, Mac. We took it depends out. We didn't give them that option.
Okay,
so
good. That's good.
So the 18% saying it depends were actually saying they wait for the second episode. And the D that said surgeon dependent were actually saying based on imaging. Well, what's the period of time for those that are in that group, which is most? What period of time does it need to persist for you to say, okay, we're going to go to the OR?
I'll comment a little bit on the it depends category. We serve in El Paso, Texas, a fairly transient population, so it also depends on their migration status, if they're going to get lost to follow up, and how likelihood, what's the likelihood it's going to recur. So there are some access to care issues that we do consider when we're performing this procedure.
Okay. All right, let's go to the next question. So you place a chest tube, the pneumothorax is fully evacuated, the next day the chest tube is removed, The patient's doing great, sends home. You send them home. What do you do in clinic when they come back? Do you just give them reassurance, say you're fine, send them on their way, or you order a chest CT or a chest MRI, or you offer them elective VATS? And it looks like the vast majority of us would not do anything much more after that. So I think most people, it sounds like, are waiting on the second episode. Okay, let's go next. Oh, we're going to skip this one. Let's go. Can we go to the next one? Yeah. So for anybody who picked VATS, when you're in the OR, let's say you resect the visualized bleb disease, what do you do with the pleura? Nothing, mechanical abrasion, chemical pleurodesis, or pleurectomy. Looks like we got like a 2/3, 1/3 split between mechanical abrasion and pleurectomy. Anybody feel strongly that it should be one or the other and want to tell us why? Or feel moderately and want to tell us why? Yep, there's Katie, if you go over there. And then when we finish the last case, please don't leave, because Dr. Marion Henry, one of our program chairs, has a very important announcement to make before everybody leaves. Yep.
So if you're operating for bleb disease and you see blebs and you staple off the blebs, what are you adding by doing a mechanical pleurodesis or a pleurectomy? So the theory is that you're going to get adhesions, and if they get another pneumothorax, it's not going to fall completely. But the reality is, if you're treating a very specific disease, if you're treating specific blebs, that really should be adequate.
You're right, it should be, but a lot of times it's not adequate, and the pleurodesis actually shows that decreases the risk of a pneumothorax post-op compared to no pleurodesis. But you're right, it should. I like it because when you do a pleurectomy and you get all that blood, it acts as a blood patch too.
Can you explain how you...
Yeah, so I do a partial pleurectomy and just use a cautery with the Maryland dissector, and just kind of start to cauterize around where I want to from the apex, strip it, and just roll it up like you're rolling up spaghetti on a fork, and it just strips all the way down as much as you can, and as far down as you can go.
So that's pleurectomy. Yeah. Who does mechanical pleurodesis? Can we hear how you do that?
I do have partners that do pleurectomy, and we recently had a recurrence where right where the pleurectomy was, it was still stuck, but on the sides it completely collapsed. But I just take a Bovie scratch pad, fold it in half, put it through one of my port sites, and just scratch the hell out of the apex.
Through a 5-port?
Mm-hmm. Yeah.
Okay, okay.
Yeah.
Did you hear that? Maybe I'm the only one that doesn't know. Cut it in half and stick it in a 5-port and scratch around. All right, let's go. Next question.
I think we got to call it right there.
We're done, okay.
I don't want to get the dancing cactus on, on my
let's
session.
not get that. We got 2 more days of this.
All right, well, thank you, everybody, for your participation.